So it begins. Welcome all to, bienvenidos a todos primero a esta sesión de USP Latinoamérica. Hoy tenemos una invitada especial, Dr. Raji. Dr. Raji is going to present an awesome theme. She is a senior attending pediatric intensive care and cardiac intensive care in Apollo Children's Hospital in Chennai, India. And she's going to talk about right ventricular pulmonary arterial coupling in pediatrics and its association with also VExUS. So without further introduction, I welcome Dr. Natraj to present us this great conference.
Thank you, Alfredo, for the introduction, and I thank Javier as well for inviting me. I'll try to go as slow as possible. So this is what we did, right ventricular pulmonary artery coupling in children, and we wanted to see how VExUS is associated with this. So the association between VExUS and right ventricular PE coupling in pediatrics. So normally we all know that, left ventricle is given importance and right ventricle is not given as much importance as left. Of course, in the last 1 decade, there are several studies showing the importance of right ventricle. So initially it was thought it was just a sac to transmit blood from the peripheries to the lung. And the importance of right ventricle was, the weakness of right ventricle was less important in heart failure. So only later did Guyton show that RV is very important simply because the contraction of the RV keeps the right atrial pressure low. That is the PRA, which is the right atrial pressure low, so that your mean systemic pressures is quite higher and you maintain the gradient mean systemic pressures and the right atrial pressure. So if your RA pressure is low and the PMSF is high, you have a good venous return. So how is this right atrial pressure kept low by the right ventricle? So that depends, that's all because of your, what you call the anatomy of the right ventricle. So if you see right ventricle here, it is quite ellipsoid. Look at the shape of the LV, it is quite, conical, whereas the right ventricle is more spherical or ellipsoid and it covers it wraps the left ventricle. And the geometry, apart from the geometrical shape, if you see the surface area is also quite large when compared to LV, and it can accommodate larger volume with less increase in pressure. So, and additionally, it is thin-walled and it is more, much more compliant when compared to left ventricle. So these are the features, anatomical features, which helps to maintain the right atrial pressure very low. So for other physiological consideration in the RV is, RV needs less energy to pump, unlike the left ventricle. It needs only 1/6 of the energy. And the work done by the right ventricle is much less, and the PVR, is much less when compared to SVR. SVR is in thousands, whereas PVR is in just 2 digits. So it's only 1/10 of the resistance. So you should also remember there are different contractile properties of the right ventricle. The right ventricular free wall, right ventricle has several contracting properties, So one is the longitudinal fibers, which is this part, which helps pulling towards the apex. This is what we do, the TAPC, and it has other contraction methods from the LV. So majority of nearly 40% of the LV RV contraction is assisted by the ventricular septum and assisted by the LV. So that's why when the LV fails, RV also fails because of the shared septum, and the contribution is quite substantial, which is close to 40%. So when we assess RV, we need to look at all the contractile properties of the right heart. So how does it differ? As I explained earlier, it is very highly compliant. It works against low resistance, that is the pulmonary vascular resistance is low. So it can accommodate high volume and it is low pressure chamber, the muscle mass is also very less. You know, the LV is very thick, has thick muscles. And remember, the perfusion occurs both in systole and diastole in the right ventricle, whereas it occurs only in the diastole in the left ventricle. So see, these are several physiological differences between the right ventricle and the left ventricle. So you know, the acidosis, hypoxia, positive pressure ventilation, and hypercapnia can all increase the PVRI. But the same factors, acidosis and hypoxia, can decrease your resistance, that is a systemic vascular resistance, and cause vasoplegia. So there is a substantial difference in the physiological aspects with respect to right ventricle and left ventricle. So I think we need to remember these properties, both anatomy and physiology, and how it differs with respect to the resistance. So coming to, so now why we understood that why RV is important and what are the differences between the right ventricle and the left ventricle. Now let's see what is the relationship with the lung. So this right ventricular PA coupling, it's simple, nothing but the heart-lung connect. So whatever the blood received by the RV is pumped back into the, pumped to the left, to the lungs and further into the left atrium and ventricle. So the RV and the pulmonary circuit is a one functional unit. It is the interaction between the RV contractility and the pulmonary load. And it determines how effectively the RV converts the energy into the forward flow. So there are several factors which can affect this, which we will see subsequently. So remember, we discussed already the right ventricle is thin-walled and it faces the low resistance. And what we see, the pulmonary pressures or the pulmonary hypertension or afterload is a lumped component. It is affected not only by the resistance, which we commonly talk, which we measure on the catheter in the right heart studies. It also depends on the arterial compliance and the wave reflection characteristics. So there are ways to measure this, but what we generally talk about is the pulmonary arterial pressures, which indicates the PVR. So remember, it's a lumped index. It's not it's the only factor contributing the PA pressures. The arterial compliance and the wave reflection also contributes to the PA pressures. So what is RVPA conceptually? It is basically how well the RV contracts and how low the pulmonary afterload is. So a good contracting ventricle under low pressure in the lungs are important, so that effectively the blood flows into the lungs. The energy transition or transfer is very simple. Less energy is required to pump the blood into the lungs. So if you can see here, the LV, the red one is LV, it contracts, and this is the opening of the aortic valve. It opens, the aortic valve opens, the blood is ejected, which is the ejection phase, and then it comes back into the diastolic phase. So if you see, the LV stops ejection, but the RV continues to eject little for longer time, much more than the left ventricle. So the physiological principles are different. If the contractile properties are good, it will eject out freely into the lung. So how do we measure this RV-PA coupling? For that, we need to know the PV loop, which is usually measured in the cath lab with the conductance with the catheters. So here, if you see, this is the end diastolic pressure. And as we know this, the isovolumetric contractions begins here and the ejection phase begins here. And then it goes into the relaxation and the diastolic phase will begin. When the mitral valve opens, the diastole begins and the LV gets filled up, RV gets filled up. So if you see this line, which indicates this one, when you come back to the base, this is the end diastolic phase, and this indicates the EA, which is called the arterial elastance. On the other hand, if you draw a line across the peak end systolic pressure and bring it down here to the base, this is the volume which is 0 at the beginning of the diastole. This indicates the ESPVR, which basically the contractile property of the right heart. So this is the contractile property of the heart, and this is the contractile, this is the slope of the arterial, which is called the elastance, arterial elastance. So we measure ES by EA, which gives you the coupling ratio. So how is it actually done? Optimal coupling ratio, we know that ES by EA is normally it is 1.5 to 2, the ratio, which indicates the stroke work is enough and heart is mechanical efficiency of the right ventricle is very good. If it is uncoupled, the ES by EA, which is called the coupling, will be less than 1. Basically, the right heart fails to generate, the energy is not sufficient to pump blood, so there is uncoupling. So, you remember, it's not in the RV cannot take the high afterload acutely. It will fail. Suppose if there is chronic pulmonary hypertension, the RV gets adapted slowly and the coupling is maintained. So this is called the compensatory phase. When it goes into the maladaptive phase, where we see generally in ICU, when sudden increase in lung pressures or PA pressures, for whatever reasons, be it is high ventilatory settings or pulmonary embolism or whatever it is, there is sudden failure of the right ventricle just when the uncoupling occurs rapidly. So that there the coupling ratio falls to less than 1, and that has a bad prognosis. So the blue one indicates the healthy right ventricle. This is the compensatory loop, the green one, which indicates the adaptation is there, coupling is maintained between 1.5 to 2. And the red one indicates the maladapted or non-adapted, where the coupling ratio falls to less than 1 and the RV failure will occur rapidly. So how do we measure all these? This is, as I said earlier, it is measured in the right by using the catheters, the conductance catheters under various loading conditions. Routinely, it's not performed. It's a bench study, you can say. It can be not routinely performed, but how can we do at the bedside? RVPA coupling at the bedside. So it's very simple. We all know the right ventricle contraction is important, the assessment. The first thing when the right ventricle fails is the IVC gets dilated. And the abdominal contraction, as I said earlier, there are several components of the contraction factors we have to look for. What we routinely look at the TAPC or the FAC, which indicates that the RV function is good or bad. So you can see on the right image here, RV contraction is little poor. The RA is dilated when compared to the image on the left side. So abdominal contraction associated with the dilated IVC and the TAPC, which looks very normal here. So if you can see the RV contraction or the longitudinal contraction is poor, you can see the tricuspid systolic motion of the tricuspid annulus will be less. So you get a small waveform. Again, in children, there are several, it's not a single value like in adult. You have Z-scores for different age groups. And if you see, because of the fail, you may get a TR jet as you put a color Doppler across the right ventricle, color flow Doppler. So on this continuous wave Doppler, you get a beautiful TR jet if there is right ventricular dysfunction and the TR. So this TR velocity, which is called TRV, is used to calculate your systolic peak pulmonary pressure, PA pressures. So systolic PA pressures is 4 times the square of the TR velocity. Suppose this is 4 into 4, 16 into 4 is 64. So that's how you calculate the peak systolic pressures in the pulmonary pressures. You add your right atrial pressures if you have, that gives you your pulmonary pressures. So you can, so now you calculate the systolic pressures, and the next is you need to know what's happening into the RVOT, right? That is where you see the pulmonary velocity jet. So in your short axis view, you can see the RVOT outflow tract here. Okay, this is a SACS view. So this is the right ventricular, right atrium, and you can see the pulmonary. You just put a pulse wave Doppler, you get a beautiful V-shape, tongue-shaped curve. This is called the VTI of the right ventricular outflow velocity. So this is normally a V shape or parabolic shape, and the peak acceleration time, pulmonary acceleration time from here to peak here, that should be more than 130 seconds. That indicates it's normal. Suppose if it is short, like less than 120 in children, we say that the PA pressures are high. Okay, so we can calculate PA pressures objectively by looking at the RVOT or VTI profile, or we can even calculate your systolic pressures based on the TR jet velocity. So you can see here, the velocity is rapidly rising and reaches slowly. This indicates the PAT or the acceleration time is less. If it is less than 120 or less than 100, it's very bad. That indicates the PA pressures are high. Another important thing is the notching, which you see here, which is often seen in some kind of embolism, where, which is not much often seen in children. So looking at the RVOT profile, the TR velocity, and with your right atrial pressure, you can calculate the RVPA coupling at the bedside. So again, you need to know whenever you find a big TR jet like this, you need to know whether it is precapillary or postcapillary. Postcapillary is usually due to severe left ventricular dysfunction. Your LVEDP is high. As a result, the PA pressure goes up. And simultaneously, you'll have to look whether there is any diastolic dysfunction on the left side. If it is low, you know that the LVEDP is high and that is causing your pulmonary hypertension. So why it is important to know whenever the PA pressures are high or the TR jet is there, is it because of the left ventricle or is it because of the right ventricle? So isolated postcapillary dysfunction, high PA pressures, because of postcapillary, the treatment is different when compared to right. And if you see a PAT which is low, as I described earlier, or if you see any notching, that means the patient has precapillary, the PA pressures. And also you can see the PR jet if you place the pulse Doppler across the RVOT outflow. You can see a significant PR, then you know the PA pressures are very high. So you need to categorize the patient whether it is precapillary or postcapillary. So whenever you see high PA pressures. So how can we do with assess at the bedside? We discussed already. We know how to calculate TAPC and we know to calculate the systolic pressures. So this indicates a surrogate of contractility and the afterload, that is the PA pressures. So the ratio of TAPC by systolic PA pressures indicates this component indicates that RVPA coupling at the bedside. A cutoff value is less than 0.31 millimeters, 3 millimeters of mercury. So other ways you can do is you can calculate the RV free wall longitudinal strain if you have the software, or the best way is to do is the fractional area change. You can calculate the area of the RV and the ratio of the and this is systolic pressures of the pulmonary pressures. And of course, the RVOT profile, which we just saw. So again, this is a repetition, I think. So notching indicates severe pulmonary vascular disease and the vascular compliance may be poor. So now we need to see what the inability when RV does not adapt to the loading condition, what happens, we know the RA pressure will increase and you know the IVC gets bulged or dilated. So as a result of which it is reflected on various organs because the high back pressures, especially the hepatic, portal and the renal. So all this lumped together is a VExUS, venous excess in ultrasound. So the main aim of our study was to see, since we can high VExUS score alone can predict RVPA coupling at the bedside. So this was the main aim of our study. So this was done in 2025 and a set of post-op cardiac patients in our hospital. So we wanted to know the relationship of VExUS to echocardiographic components, that is RVA coupling, which we just explained. So our hypothesis was the higher VExUS score will reflect worsening RVPA coupling. And also we wanted to look whether the portal vein score alone, since it is very easy to perform at the bedside, whether portal vein score alone predicts the coupling. So it was a post-hoc analysis of our previous study. It was a single center prospective study. So what we did, we analyzed all the hemodynamic data routinely as we do, plus the echocardiographic finding, which includes the TAPC and the PA systolic pressures. And on day 1, day 2, and day 3. Of course, we looked at other measures as well, which include IVC and VExUS data. So we calculated the TAPC to PA systolic pressure using any patient who had less than 0.3 indicates uncoupling. So several studies in the past, mostly in adults, have shown there is a good correlation with the studies from PV loop. Higher values reflect better coupling. So our intention was to see whether VExUS score more than 2 or 3, is it associated with low ratio, TAPC to PA ratio. And additionally, as I said, that pulmonary vein Doppler is easy to do. Whether singly can we use it as a single component to assess the coupling ratio. So the usual statistics were comparison between the two groups, and we used a linear regression model to see, because there were multiple pressure measurements were done, like day 1, day 2, day 3. So a hierarchical regression model was used to assess the association. So totally 43% patients were included in the study. The median age group was around a year. Most of the cases were tetralogy or VSD. Of course, we had other combinations as well. And the median cardiopulmonary bypass time was 160 minutes. Most of the patients were on positive pressure ventilation. They were sedated and sedated. Yeah. So if you see, there was no major difference in the heart rate. The p-value was not significant on all the 3 days. The map was also reasonably okay. If you see, the CVP was high on day 1 in these patients, and over day 3 and day 4, they started dropping, and it was statistically significant. The TAPC was no major difference in TAPC. If you see 4.5, 5, and 6, and the PA pressures were high. Again, it was not statistically different between day 1 to day 3. If you see the coupling ratio of TAPC by PASP, it was 0.15 on day 1, and it started to get better by day 3. And the VExUS score, if you see, the VExUS 2 and 3 were 28%. It was high score on day 1 and started to get better on day 3. So you can see on this image here, the higher the VExUS score between 2 and 3, the lower was the TAPC, which was less than 0.31. So what we show is higher VExUS score is associated with the RVPA uncoupling. And you can see this, the right one, the red one, is the portal vein Doppler scoring. Portal vein score more than 2, if you see, has a lower RVPA coupling ratio, like less than 0.2, whereas the portal vein Doppler score of 3 had even lower RVPA coupling ratio, that is very low, close to 0.1. So the median TAPC in our cohort was 0.17, which is very low. And VExUS and TAPC, the RVPA coupling, had a moderately strong negative correlation. And we found that higher VExUS score was associated with worst uncoupling ratio, RVPA coupling ratio. And again, the portal vein score, if you compared between 2 and 3, 3 had much worse coupling ratio. So while both VExUS and portal vein scores were significantly associated, the model fit better with a full VExUS score. So full VExUS would be a better indicator for assessing the RVPA coupling ratio in our study, which we found in our study. So discussion bit, we showed that there, as I said, there was a moderately strong negative correlation. Why is it important? Because the RV cannot handle the volume. So the PA pressures, if it is high, RV cannot volume. So the back pressure is increased, as a result of which the organ dysfunction and the Doppler waveforms become abnormal. So VExUS and its component can be used to assess the degree of uncoupling. So in post-op, why is it important to know RVPA coupling? Because it has several implications in the post-op period. Because if a decrease in contractility of the right ventricle or the high afterload can worsen your oxygenation and cause organ injury, including kidney, and it is associated with high mortality. So that's why it's important to identify RVPA uncoupling immediately and address. So recognition is, as I said, very important. You can classify a risk stratification can be done quickly, and early intervention is important. So if you see that in the entire circulatory system, from the right ventricle to the lung to the left ventricle to the systemic circulation and back into the right ventricle. So the interface, there are several interfaces in the entire circulatory in the circuit. So what we assessed here is from the right ventricular to the RV to the lung, which is RVPA coupling, and also the capillary to the venule. Okay, so we assessed from the venules, that is the capillaries to the venules. This is the VExUS. So we use two interfaces in the entire circuit to assess the circulation. So whenever a patient is in trouble, either in shock or low cardiac output, I think we need to assess all the interfaces. RV, like from the lungs to the LA, or from the LV to the systemic, which we all know is the ventricular arterial coupling at the systemic site, just like the RVPA coupling. So we have the left ventricular systemic coupling. So we need to assess this as well. And of course, we need to assess the microcirculatory parameters along. So in this study, we assessed two interfaces, the RVPA and the capillary to the venule. So limitations of our study, it's a single center post-hoc design. We selected only children with RV systolic dysfunction. Remember, there is no reference value in children for TAPC and PASP. We just took adapted this from the adult literature, and we did not capture those children who had RV dysfunction. Several children did have, but we did not capture the data, especially the RV dysfunction. And we did not adjust ventilation and tricuspid regurgitation in the analysis, which could have impacted in the interpretation. So what we can conclude from our studies, a higher VExUS score is associated with worsening RVPA coupling, and it's an important therapeutic monitoring tool which can be useful in the post-op period, especially when the window is poor. So portal, if we have difficulty in looking at the entire VExUS, you can consider only portal vein to see if it is the score is high. So it's important not just in cardiac setting, even in non-cardiac setting, it's very important because conditions like sepsis, ARDS, and high positive pressure ventilation can increase the PA, can increase the right ventricular afterload and cause uncoupling. So in these children, we may have to adjust fluids, rather avoid fluids, or we may have to diurese, start inotropes to improve your right ventricle, and of course optimize your ventilatory settings to decrease your PA pressures. So it's the same thing with pulmonary hypertension, the coupling can be worse. Uncoupling indicates mortality can be worse. So you have to restore as early as possible the coupling ratio. Remember again, always look for the left-sided failure. That also can increase your pulmonary load and increase the RV strain or dysfunction. So it's very important that we maintain both right ventricle and the left ventricular functions. So how do you improve the RVPA coupling at the bedside? How do we bring back the ratio to 1.5? So use the pulmonary vasodilators if the PA pressures or the pre-systolic or pre-capillary PA pressures are high. Of course, correct hypoxia and acidosis. Improve your contractility using any inotropes such as dobutamine or milrinone. Optimize your preload. Most of the times you may have to diurese these patients because RV is struggling and the septum is to the left. So they usually have the pressure and volume afterload. So diuresis is important. And of course, if nothing works, you may need ECMO or the RV assist device. So key message is, it is often seen in children. It's not just adults. We need to look for it. Several factors can impair the coupling ratio, especially the ventilation and cardiac dysfunction in ICU setting. TAPC by over the pulmonary systolic pressures is a quick and practical tool to recognize uncoupling at the bedside. And we found additionally that high VExUS score may be complementary rapid marker. So it's important to recognize and intervene all the interfaces in the circuit. I think that's the last slide. Thank you.
First of all, I would like to congratulate Dr. Raji for that awesome and magnificent presentation. So congrats on that paper. I was reading that paper with alongside a bunch of other papers from your group, for your study group. And I would like to ask you a couple of questions about the paper, which is, by the way, it's a groundbreaking paper when you talk about VExUS and its relation with the coupling. So my first question will be probably, because VExUS may reflect congestion from multiple mechanisms beyond RVPA uncoupling, how do you recommend clinicians differentiate whether a high VExUS score is driven primarily by impaired RV coupling versus other factors, such as, I don't know, RV diastolic dysfunction, elevated intrathoracic pressure, or fluid overload? How can you separate from that?
Yeah, it's a very important question. The VExUS score can be high for several reasons, right from right ventricular dysfunction to the problem with the RA compliance, or it could be because of the lung problems. So effectively, or it could be even pericardial pericardial collection compressing the RV. So there are several endotypes of, VExUS congestion score. So we need to figure out first what is the main problem. Is it because of the TR? Is it because isolated RV dysfunction? Or is it because of the PA pressures? So eventually what we are looking at here is whenever if we rule out other treatable conditions, like especially the effusion, we know the next question comes is it because of the RV failure, or is it because of the high PA pressures? So eventually these two problems are the ones which we often see, and as a result of which the RA pressure goes up and you see higher VExUS score, including the dilated IVC. So I think once you find a high VExUS score, we need to look more deeper into the into the entire circuit, whether is it RV dysfunction, is the PA pressure high, or is it only one, and treat each component. It's not just one, either PA pressures or RV dysfunction. So whenever you find a high VExUS score, you next look into the RV function and your PA pressures, and of course your mechanical ventilation, is it causing the PA pressures are high because of that? So there are several factors, contributing to the high VExUS score. So it's not that simple that you see high VExUS score, you need to diurese. You may have to diurese, you may have to drain the pericardial fluid, you may have to give pulmonary vasodilators, you may have to give inotropes, or decrease the titrate your ventilatory settings. So it's what we found in this study was whenever you see a high VExUS score, since these patients already had RV dysfunction and RV diastolic dysfunction, we found that it may indicate high RV-PA uncoupling. Not in all, but you have to think of RV-PA coupling whenever you see high VExUS score.
Perfect. Another question I would like to ask is about external validity of the study. For example, since you included only children and you established it well in your limitation, but since you included only children with established RV systolic dysfunction, to what extent do you believe that the VExUS TAPSI PCAP ratio relationship applies to postoperative patients with preserved RV function, for example?
You might have, suppose you have a TR for other reasons, anatomical reasons, you may have VExUS score. So we took children, most of the children had RV dysfunction. We didn't include children with RV dysfunction. So whoever had, right-sided pathology, like tetralogy, for example, we took those children, and incidentally, we found most of them had RV systolic dysfunction. And actually, we didn't capture the data on diastolic dysfunction. I presume most of them had, because majority of them were tetralogy of Fallot, where most of the children would have had diastolic dysfunction. So that is a limitation, I would say. So I think most of the children would have systolic dysfunction, but there are several other reasons, like, anatomical tricuspid stenosis and RA pressure can be because of high, or even junctional ectopic tachycardia. So many other reasons, So whenever you see high VExUS, I think there are several things to consider. It's not just RV systolic dysfunction. Look at the diastolic dysfunction and other arrhythmias as well.
Okay. Just the last question I would like to ask you.
Yeah.
It's about precisely one thing about the statistics I would like to know. So do you explore any non-linear relationship between VExUS and TAPSI PSAP? So why do you choose a strictly linear hierarchical model, for example?
So basically, since we had several days, it's not just one day we compared. We did on day 1, day 2, day 3. So since it was not a single linear model, so we had to take hierarchical model from day comparison between day 1 to day 2, from day 2 to day 3, and from day 1 to day 3. So that's the reason we took this model of, calculating rather than a straightforward linear model.
And I think that the paper, the results may lead to another subgroup analysis in the future.
Yeah.
Yeah, so you can from the same sample you can do several other subgroup analysis, I think.
Yeah, absolutely. So this was one of the subgroup analysis. The original study which we did was to see the association with the AKI. How many children with high VExUS score had AKI? We had significant number of children, had AKI. So this was one of the subgroup analysis of the original study. So as you say, we can do several subgroup analysis. You're right.
So once again, I would like to congrats on Dr. Raji. It was a nourishing session. I learned a lot, and I think all the members from USP Latin America are very grateful with your conference and dissertation this Saturday, and will allow us to cooperate with Latin America with studies and VExUS and congestion and its relationship with another variables on the post-cardiac ICU. So, like Javi said, previously, I would like to welcome you to the Latin American group, and it is a great experience for us having you in this Saturday. And if anyone in the room would like to ask you some questions to Dr. Raji, she's open to respond.
Yeah, I'm glad you liked it. It was useful.
No, it's very, very useful, and it sets a path. It says it's groundbreaking for us to have these papers as a setting point to another research in our ICUs.
Yeah, absolutely. Yeah, I think it's nice to collaborate with you people, Latin American people as well. You people are doing more research, I suppose, than us. Ours is we are in a tertiary center. It is completely private or corporate setup. So it's very hard to do research in centers like us. So I think you people are doing much more work than what we are doing. We would be glad to collaborate with you.
Thank you. We are joining forces in the future.
Yeah, sure.
So once again, I used to Javi. There's Javi.
Thank you very much.
Thank you.
Once
Thank
again,
you so much.
We would like to say thanks, and if Javi tiene algo más que decir.
Le damos las muchísimas gracias y a toda la gente que se ha conectado también. Muchísimas gracias por esta nueva sesión de Autores en Vivo. Thank you very much, Raji. I'm so happy to hear you, and always we learn with you. So thank you very much, and good Saturday, good day for everyone.
Thank you. Thank you so much. Happy weekend. Yeah. Pleasure to be part of this. Bye-bye.
Bye.
Bye.